Hello, everyone. My name is Melissa Manduhano on behalf of Cedars-Sinai Community Health Improvement. We thank you so much for being here today. As a reminder, we'll have everyone muted during this presentation, and we ask everyone to wait until the end to ask any questions. Any urgent questions can be typed in the chat and directed to myself. Today's health and wellness talk is on beyond blood sugar, understanding the diabetes heart health link. But before we get started with the presentation, I'd like to first introduce our speaker for today. So, Dr. Tadwalkar is a consultative cardiologist and partner at the Pacific Heart Institute, an affiliate of Cedars-Sinai. He is board certified in cardiovascular disease, echocardiography, cardiovascular CT, nuclear cardiology, and internal medicine. Dr. Tadwalkar provides a full range of non-invasive and invasive diagnostics, as well as conventional and novel therapies. Dr. Tadwalkar also serves as a clinical investigator, actively contributing to several major research trials. So, welcome, Dr. Tadwalkar.
Great. Thank you so much, Melissa, for the introduction. And I just want to make sure you can hear me okay. Just give me a thumbs up. Okay, fantastic. So you can see the slides here. We'll cycle through this. Make sure to keep it relevant, keep it fun, keep it exciting, but we'll also be scientifically inclined and make sure we cover all of the major aspects of modern day disease course, evidence, treatment paradigms for both diabetes and how it relates to heart health. And that's really why we're here today to talk a little bit about the interaction between diabetes and heart disease. Many people feel as though where could the interaction potentially be? But hopefully, over the course of this talk, you'll see why these two issues are linked as much as they are. And it should be a fantastic presentation and discussion that comes out of it. So before I get started, I just wanted to give a couple of plugs to sort of my own background and sort of where I practice, which is Pacific Heart Institute. We are a practice that's affiliated with Cedars-Sinai. We provide diagnostic and therapeutic cardiovascular services for patients across the West Side, Greater Los Angeles, and beyond. A lot of patients do travel to come see us. And our practice brings together cardiologists across multiple subspecialties. This allows us to have close collaboration with patients for complex heart and vascular conditions. And importantly, all of that care is centered around a personal cardiologist who helps guide that evaluation, treatment, and the long-term plan, which is really what makes our practice special. Additionally, for patients who prefer enhanced access and continuity, we do also offer a concierge-style care model. It's designed to support more individualized communication, coordination, and things of that nature. In our locations, currently Santa Monica, Marina del Rey, where we are burgeoning and growing quickly. We are involved significantly in the development of the new Cedars-Sinai Marina del Rey Hospital, which if you've driven past that area, if you're local, you've seen how much progress has been made on that hospital and that building. We do also have an office in Beverly Hills as well. We do inpatient work over at St. John's Health Center in Santa Monica, and also at Cedars-Sinai Medical Center in Beverly Hills, where we are available for consultative work and procedural work as well. And I do also want to give a plug before we get started to our nonprofit, which is called Have a Heart, Save a Heart. It's a nonprofit focused on women's heart disease, but we use that as a starting point to talk more about awareness and education and community engagement. So we really bring together physicians and other healthcare professionals to create events and digital resources, have community conversations to talk about cardiovascular education and bring it to the public. And some of these key initiatives I did include here. We do an annual Women's Heart Symposium every February. We have these Heartside chats that we do also broadcast on YouTube. A 33% pledge, where we are sort of pledging people's efforts and times, because 1 in 3 women are affected by heart disease significantly, and creating more patient and community education. In fact, I put a little flyer up there on the right for our next upcoming Heartside chat, which is not too far away. You can check us out on the web, just serve this on Have a Heart, Save a Heart, or on social media to learn more if you're interested. So with all that said, thank you for listening to just that initial part. Let's get really into the meat of things. They're just my disclosures, none of which are relevant to the talk today. We'll be speaking mostly in generic terms, just in commercial terms where needed. Now, what will we cover? So we want to talk about what diabetes is and why it is so common. We want to talk about how diabetes affects blood vessels, kidneys, inflammation, body weight, heart failure risk. So you can see that diabetes touches just about everything in the body. And what have modern cardiovascular outcome trials taught us? So a lot has changed in the diabetes landscape in the last 10 years or so, and we want to bring that to light. Of course, we want to empower you, talk about lifestyle tools that protect the heart and metabolism, and talk about newer medications and therapies that can concurrently protect the heart and the kidneys, which has become so important to us as cardiologists, which may seem a little out of left field, but there's so much of a connection between the heart and kidneys, and this goes much beyond blood sugar. The main message today is that diabetes is one of the strongest risk factors for cardiovascular disease. And the heart, blood vessels, kidneys, metabolism, body weight, all of this is biologically connected. The body all sort of functions together. Modern treatment is not only about lowering glucose, whereas in the past, that was really the main metric that we were shooting for. The goal now is not only to do that, but we want to prevent heart attacks, strokes, heart failure, kidney failure, and premature death. All the amazing things that we want to do for someone who is afflicted with this type of diagnosis. So, what is diabetes? So, many of you may find this fundamental, others may just want a little bit more insight. But diabetes means that the blood glucose is too high. And in fact, you can look at this diagram here on the right, where when there is high blood glucose, you can see how there's just more of these particles floating around through the blood vessel. And when glucose rises, it could be for a few different reasons. One is that, well, you don't make enough insulin. Insulin is the molecule or hormone that essentially helps clear that glucose out of the bloodstream. In other instances, you cannot use the insulin well. You have intolerance, impaired glucose tolerance, or insulin resistance, as we'd like to say. You could even have a mix of both. And over time, what can happen is that high glucose and insulin resistance can damage blood vessels, nerves, kidneys, eyes, and the heart. Why is that? Why is it so systemic? Well, to be honest, blood vessels go everywhere. So as a result, any organ could technically be affected by diabetes. And we're going to show you a couple of diagrams that really bring this to light in a moment. And A1C is a metric you've probably heard of and you're very familiar with if you've been to the doctor. Basically, this is an estimate of the average blood sugar over 2 to 3 months. So it's a nice metric, an easy one for us to track. It's reported as a percentage to give us an idea of what someone's glucose tolerance is. Now, there are different types of diabetes. Pre-diabetes is glucose above normal, but not yet in the diabetes range. In type 1 diabetes, you have an autoimmune loss of insulin producing beta cells. These are cells in the pancreas that typically produce insulin to tone down that glucose. And it's technically a loss of those cells. And as a result, glucose just remains rampant and runs free in the bloodstream. In type 2 diabetes, we have insulin resistance and also that progressive beta cell dysfunction. And in gestational diabetes, which can affect women who are childbearing, diabetes is first recognized during pregnancy and then can potentially persist. And if it does not, it could still be a future cardiometabolic risk marker. You may have heard of other types of diabetes, like if you go read like diabetes 1.5, you may ask, what is that? And basically, it's type 1 diabetes that happens in adulthood because typically we think of type 1 happening in childhood. You may have heard of type 3 diabetes, which is a little bit more of a media term and is used to sort of discuss the role between diabetes and metabolism and brain health. It's often been discussed in the context of Alzheimer's. So I just want you to know that you may hear these additional terms, but in reality, it's really these specific types, type 1, type 2, and gestational, that we would academically speak of. Now, importantly, diabetes is a huge problem. 40 million people is the estimated number of people with diagnosed or undiagnosed diabetes in the United States. And you can see that a sizable percentage here is undiagnosed. And in fact, a large number of people, over 115 million over the age of 18, have pre-diabetes. And the vast majority of these people are type 2 as opposed to type 1. And so the key problem here is that many people have this diagnosis or have pre-diabetes and they don't know it. And it often travels with other conditions like high blood pressure, abnormal cholesterol, obesity, fatty liver disease, kidney disease, right? It's really systemic issues. And the cardiovascular risk, importantly, begins years before symptoms. And that's the key point. That's the problem that we're faced with. So why is diabetes a cardiovascular risk amplifier? Well, high glucose can injure the vessel lining. And in fact, you can have macroangiopathy and microangiopathy. So essentially, things that affect the blood vessels at scale, like endothelial injury and atherosclerosis. And you have microangiopathy, which includes things that are on the microscopic level. But as a result, you can see here in this diagram, it can affect the arteries of the brain, right, which can lead to changes in the vasculature and brain function, can affect arteries of the eye, which can cause retinopathy. It can affect the coronary arteries both on a macro and micro level, not just in terms of plaque and development of narrowings, but also the way the artery itself functions. And the same goes for the arteries in the kidneys and in the peripheral vessels, like the legs, for example. And this all happens in parallel with high blood pressure, kidney stresses, etc., lipid handling, and visceral adiposity, which often comes with diabetes, that just means sort of fat that is sort of surrounding the organs, can promote further inflammation and other conditions. So all of this biology is connected and it can affect the whole body all at once. So this is why diabetes is so important to recognize. In plain English, to keep it simple, the blood vessel lining in diabetics that are uncontrolled becomes less flexible and more inflamed. You have more LDL particles that can enter arterial walls. You can affect the kidneys as well with filtration pressure. Albumin can leak, which is a form of protein. We often check for this in the urine. And it can affect the heart muscle biology, higher risk of stiffness, congestion, and forms of heart failure. And the important thing to note here on the right is just a sort of a representative diagram of how, diabetes can affect the kidney. But the important thing to know also with the visceral fat that comes with this, that fat is metabolically active. It is an active inflammatory organ. So when we talk about this fat, beyond just how it looks or what it might do to other organs, there is an actual active inflammatory component, which is why we care so much about trying to eliminate this visceral fat. So what are some common complications people hear about? Well, diabetic retinopathy, we talked about in the eyes, protein spilling through the kidneys and the urine, which can cause declining glomerular filtration rate, kidney failure, neuropathy, ulcers, infections, because it can affect the nerves, the brain. There's a stroke and cognitive risk, which is now becoming so much more apparent. The heart and arteries because of heart attacks, coronary disease, peripheral arterial disease, heart failure, so on and so forth. So this is not to scare you. It's just to let you know that, hey, this can in fact affect every organ and this is how it does it. Now let's talk about the cardiology view because at the end of the day, I am not an endocrinologist, I am a cardiologist. And you may ask, why is a cardiologist talking so much about diabetes? But again, it's because the most feared complications of diabetes are blood vessel or heart related. And there's three specific buckets that we would put these complications in. There's atherosclerotic disease, which means you have the narrowing and thickening and plaque development inside of the blood vessels, heart failure, which is congestion and shortness of breath, right? Because of the pumping function of the heart being inadequate. And then kidney disease, which can cause problems with the filtration. And that in of itself can cause higher cardiovascular risk beyond just kidney failure. So modern prevention tries to reduce all three of these because now we have fantastic therapies that allow us to do that. Now, a recent, very recent, this is just within the last couple of months, article came out in Circulation, which is American Heart Association's journal, talking about CKM, cardio-kidney-metabolic health. So this is what I was talking about these overlap syndromes and how the heart and kidney are very interrelated. And there are different stages of CKM because it is a syndrome. There are a number of different aspects altogether. It starts with this excess and dysfunctional adipose tissue, that visceral fat that we talked about that was quite inflammatory. Then from there, as it progresses, we talk about some of these medical conditions that come up in visits: high blood pressure, high lipids, high triglycerides, type 2 diabetes, CKD. Then we move into subclinical ASCVD, which is just a fancy way of saying that you can have some plaque develop thereafter inside of the arteries that becomes apparent on scans, but you might not feel or recognize. And subclinically, on studies like echocardiograms, where we're doing ultrasounds of the heart, we will actually see increased stiffening and changes of parameters that suggest that this is now affecting the heart subtly before stage 4, which is when the clinical syndrome of CKM comes to light: heart failure, chronic kidney disease, stroke, AFib, peripheral vascular disease. All of this kind of happens as the end stage. But you can see there are many stages prior to that where we have an opportunity to prevent things. So this is why it's important for you to know your numbers. These are the things that we look for when we have patients come to their visits: their A1C, their fasting glucose, what is your blood pressure numbers. We'll go over some of these in further detail a little later. Your lipids, which are code for cholesterol, right? And the different types of cholesterols, LDL-C being a big one because that's the bad cholesterol. Kidney function, looking at the GFR, glomerular filtration rate. More recently, we've been looking at something called urine albumin to creatinine ratio, looking for that microscopic amount of protein in the urine. Your weight, your risk, have you done calcium scanning? Because there's a number of patients who qualify for that. So these are the kinds of numbers that, yes, it's an increasing degree of numbers than we had to know in the past, but it's helpful to have even a partial understanding of these because it helps empower yourself in terms of your health, and it brings a lot to the table for your visits with the clinicians. So when we look at diabetes care, at first it was all about glucose and A1C. But as we've moved on, we've talked more about risk factors like blood pressure and lipids because it all plays into it. Now we're moving into step 3 in that diagram, that outcome-centered care. What is the diabetes doing to your body? How are we preventing it? What are we doing with this ASCVD prevention, meaning preventing coronary disease and atherosclerotic disease? How are we preventing heart failures, kidney disease? How are we keeping your weight down? This is where the modern trial comes in. And these are the ways that, modern cardiology has stepped in to help take care of patients with diabetes. So I'm going to go through a series of clinical trials, but before we go off into it and get into a lot of minutia, I'm going to keep it very high level, just so you have an idea of how this whole field has shaped. So when you look at a clinical trial, these are some of the key things that really, as a layperson or someone who may or may not be in the healthcare space, things to look for. Who was studied? What were they looking for at the end of the day? How much did a specific intervention help? What's the number needed to treat? We often talk about NNT. How many people needed this treatment to prevent one event over a period of time? And most importantly, the clinical meaning. Does this trial apply to me as a patient? Because there's a lot of great trials with a lot of good results, but you may not necessarily fit that patient population that was studied. So those are things that are important. So to jump into that, I want to talk about a class of medications called SGLT2 inhibitors. It's a little bit of a mouthful, but essentially what they do in brief is that they help eliminate blood sugar through the urine. But they do much more than that. In fact, a lot of the mechanisms we have learned by studying what the outcomes of the drug were. And we're still kind of sussing out some of those mechanisms, but we know that it helps protect the kidney. It can lower the risk of heart failure in selected patients. It can potentially reduce fat mass, maybe preserve beta cells, reduce fatty liver. So this became one of these drugs that we thought was just, hey, we're getting rid of we're getting rid of sugar from the blood. But it turned out that there were all of these additional benefits, which is why we, began studying it in much more depth. In fact, the first major outcome trial that really validated this was on a drug called empagliflozin, which is also known as Jardiance. And we saw in a very large population with type 2 diabetes and established cardiovascular disease that it cut the likelihood of cardiovascular death, heart attack, and stroke all together with a really good hazard ratio and with a reduced likelihood for hospitalization. So these are just event curves, and you'll see these in the next few slides. But it's just showing you versus placebo how well this medication fared over a period of time. And you can see the event rate. So you're looking to see how those curves separate on the left side panel. So the key point is that we found out that medications like Jardiance, empagliflozin, SGLT2 inhibitors, the class, can reduce cardiovascular death and heart failure hospitalization. And a number of different trials came up from there. Canvas, Declare TIMI 58, Credence, looking at various SGLT2 inhibitors in certain populations. And we saw a reduction in MACE, major adverse cardiovascular events. And throughout this, we found that hospitalization was almost entirely reduced. And in many instances, we saw protection of kidneys, reduction in cardiovascular death. So, some really fantastic outcomes on the whole, with certain agents faring better than others, which is why they have come to be the ones that are more likely to be prescribed today. In a chronic kidney disease population, looking at the same class of medications, there was trials like DAPA-CKD and EMPA-Kidney, where we looked at CKD populations even without diabetes, with and without it. And in both of these trials, in these instances, with different drugs, dapagliflozin, which is Farxiga, known as Farxiga, empagliflozin, which we talked about as Jardiance, we saw that the risk of kidney disease progression or cardiovascular death was reduced. So from these trials, we learned that these are not only diabetes medicines, but both heart and kidney medicines as well. So there are these multifactorial effects in very large scale, well-validated clinical trials. What about for heart failure? We saw that there were so many beneficial effects from this drug class. Could it impact people with heart failure? And it turns out that in patients with heart failure with reduced ejection fraction, that means the heart's not pumping the way it's supposed to, whether they have diabetes or not, we actually saw a reduction in worsening heart failure and cardiovascular death with this specific class of medications. So now this became a heart failure therapy, not just a diabetes therapy. So as the years went on, we learned more and more about this specific drug class, which has been fantastic to see in diabetics, as well as patients who may have these conditions who are not diabetic. We got a second confirmation of it again with, instead of dapagliflozin, with empagliflozin, and we saw similar outcomes. So this became much more foundational. And even in patients who have a different form of heart failure, we call it heart failure with preserved ejection fraction, which means that the heart is a little stiffer, it's more likely to become congested and lead to fluid on the body. Even in those patients, we saw that there was less cardiovascular death and hospitalization with these specific medications, dapagliflozin and empagliflozin. So this became what I would say is the key point, which is that cardiometabolic disease is central to prevention of heart failure and treatment. So this has sort of painted the entire picture of where we are with these medications. And this is just kind of a complex but important illustration from a 2023 article from the ACC that just showed that in all kinds of overlap populations, heart failure with or without kidney disease, diabetes with or without heart failure, with or without chronic kidney disease, etc., we saw benefits from this specific drug class in just about all of these patients. Now, I want to move on to GLP-1s because these are like the hot topic. It seems like everyone, maybe for better or worse, seems to be on a GLP-1. These are medications that you've heard of, like Ozempic, Wegovy, Zepbound, Mounjaro, and so on and so forth. Now, the interesting thing about GLP-1s is that they've actually been around for a good 20 years or so. The class of medications, I want to say somewhere in the mid 2000s is where we had our first GLP-1. They're actually technically diabetes drugs, which is why we're talking about it today in this talk. But it turns out that beyond treating diabetes, there are a number of actual effects that are found to be quite good. It's not just the diabetes, it's not just the weight benefit that many of you are very aware of, because it's kind of, in some contexts become like the quote unquote Hollywood drug for those who are looking to lose weight, as I said, for better or worse. But it turns out that in the correctly selected patient where the medication is indicated, there's actually a number of potential benefits. Decreased coagulation in some patients, lower postprandial lipids via its work through the intestine, increased cardioprotection. Some people worry when they get prescribed these drugs, they're like, isn't it going to affect my heart? Isn't it bad for my heart? Unlike weight management medications of yesteryear, which were rife with complications and issues back in the 1980s and 90s. You probably remember news reports of medications like fen causing all kinds of issues for the heart. These are the opposite. These are cardioprotective medications. Decreased inflammation in the fat and liver, decreased blood pressure, increased diuresis from the kidneys, and things of this nature. So there are a number of multifactorial effects with these GLP-1s. And this looks a little complex, but liraglutide, which is a very foundational GLP-1, I believe it's Saxenda, if I'm not mistaken, is in a trial initially showed with for patients who have type 2 diabetes and high cardiovascular risk, there was a lower risk for patients who took this medication in cardiovascular death, non-fatal heart attack, and non-fatal stroke. And this was the key point, which is that this was the first big trial. This is back in 2016, so this was 10 years ago, that showed that there were actual cardiovascular benefits to taking these medications in type 2 diabetics. Then we had a number of other trials. This is basically a forest plot that shows benefits of specific GLP-1 medications in how patients fared with regard to MACE, major adverse cardiovascular events. And basically, in all of these trials, more or less, we saw that there was a significant reduction in these major adverse cardiovascular events, whether it was dulaglutide, semaglutide, which is Ozempic and Wegovy, respectively, or efpeglutide, which is available internationally at the moment. We saw fewer major atherosclerotic events in these high-risk type 2 diabetics. So we saw a pattern emerge. It wasn't just the liraglutide, it was the other medications as well. Then we move forward to 2023. This is kind of like the modern day of GLP-1s, where semaglutide, again, also known as Ozempic and Wegovy, we tested it just for obesity and said, hey, if you have obesity and cardiovascular disease and don't even have diabetes, could you get a benefit? And it turned out that it did improve the endpoint of cardiovascular death, heart attack, and stroke, and quite significantly. So we saw these cardiovascular benefits with this drug class beyond diabetes and A1C. In fact, in a trial from early 24 called the FLOW trial, we saw that it also improved kidney outcomes in patients who have type 2 diabetes and chronic kidney disease. And this was a large-scale vetted clinical trial. So now it's sort of moving into kidney protection as well with these GLPs. The final class of medications I want to talk about, and then we'll get into some of the stuff that you can do to kind of advocate for yourself and make sure you're getting the best care as well, is finerenone. It's a non-steroidal mineralocorticoid receptor antagonist. Quite a mouthful, but essentially it works to prevent aldosterone, which causes a number of effects. It's not all bad, but when it's overactivated, it can cause fibrosis, vascular remodeling, atherosclerosis. We're trying to prevent that from being overactivated with this medication. And you can see sort of how this works in a mechanistic way. And there were some clinical trials early on in diabetic kidney disease looking at using finerenone, this non-steroidal MRA, as we like to say, at outcomes. And we saw a decrease in the risk of kidney outcomes and cardiovascular outcomes in this patient population with finerenone. Finerenone, just for your information, is marketed as Kerendia. So you may have heard the name Kerendia. The main issue to look out for patients who are on this are monitoring potassium and kidney function. And then later, because we saw a signal, we saw this might actually benefit some patients who have heart failure with mid-range or preserved ejection fraction. And so in those patients, we found in this trial that was beautifully called Fine Arts that we actually saw lower worsening heart failure events and cardiovascular death for patients who are on this medication. So moving forward, and then we'll kind of get past all of these evidence slides, but again, they're important to build the story, is that looking back at those GLPs, we actually see improved heart failure symptoms, function, and weight in obesity-related heart failure, specifically the heart failure where the type where the heart gets a little bit stiffer. So this is important. It turns out that the reason why, as a cardiologist, or one of the major reasons that we are prescribing these medications is because patients who have excess weight and have heart failure with preserved ejection fraction can benefit significantly from these medications with improvement in symptoms and reduction in body weight and obesity related composite outcomes. So what do all these trials mean? I thank you for sticking with me through this because I know it can be a little bit dry, but it's important. What does it all mean? Why do we paint this whole picture? Basically, we have therapies now available for whatever the mix of issues is that someone might have if they're diabetic. So if the main issue is cardiovascular risk, we have GLP-1s and other incretin therapies. If it's heart failures, we have those SGLT2 inhibitors. If it's chronic kidney disease and spilling protein in the urine, we have both of those. We even have finerenone, which we discussed. If it's more obesity-centered biology, we have all the great lifestyle things that people can do, as well as the GLPs. So the treatment is now selected by phenotype. It's not just about the A1C. So now for some of the fun stuff, what can you do from your perspective to really keep yourself heart healthy in this context? Well, there's this fantastic document. It's called Life's Essential 8. It's kind of a nice document because it's written both like along the context for like clinicians to read. It's also geared enough towards the public where you could pick it up and get a lot of information from reading it. But essentially, it talks about 8 foundational things that are exceedingly important to prevent disease processes in general, and a lot of things that we talked about today. And in fact, they're nicely sort of delineated here on the diagram. It's to not smoke, it's to get adequate sleep, it's to eat a healthy diet, exercise, follow your blood glucose, manage your weight, reduce your lipids, and treat your blood pressure. Now, this is a lot, right? No one is saying that, hey, like we need to make everything perfect. And yes, it sounds much easier to say as a sentence than to actually pull off. However, the more you can tackle each of these issues and the more dialed in, the more likely you are to have a better outcome and have better preventative health and to treat disease processes that may already exist. So the idea is that we want to do as many as we can. The best plan is one that a person can actually sustain. It doesn't have to be perfect. Now, we talk about medications a lot as doctors, but the reason we talk about it is because, in combination with lifestyle, these work remarkably well together. It's really that combination that really gives us what we're looking for. So when you think about dietary patterns, you really want to think about a cardiometabolic pattern that you want to take on, not a diet culture where it's like, hey, I'm just going to stop eating this many calories for the rest of my life. It doesn't necessarily have to sort of fit into that pattern. We really want to think about what you're eating, not always focusing on just the overall calorie consumption or one specific food for that matter. And the dietary patterns we have the most evidence for are the Mediterranean and DASH diet. DASH stands for dietary approaches to stop hypertension. These are very well there's lots of information on it, I should say, from official sources. I really like the American Heart Association for these types of information to give you very granular specifics on what to eat. These diets emphasize vegetables and fruits, whole grains, low-fat dairy, fish and poultry to some degree for protein sources, beans, nuts and seeds, uh, and vegetable oils to a degree. And I know there are also some controversies in some of these as well, which we can also discuss if it comes up. But it's pretty clear that we want to reduce refined starches. So this includes very sugary, sweetened beverages. Sodas would be a classic example. Sweets are not bad in of themselves, but you want to, limit them because in excess, which can be very easy to become excess, we start to see some big issues. Sodium intake, unfortunately, a lot of this food that we buy already is prepackaged with a ton of sodium. You certainly, at the very least, don't want to add any more. You want to be mindful. And of course, we'd say, quote unquote, limiting fatty meals, which often tends to be from large quantities of meat or perhaps red meat, which many people don't like to hear too often, but it is in fact true. So, we'd want to just be a little bit cautious with that. Although, to be fair, in small quantities, there can be some important material benefits to having those foods as well. although they can also be get you can also get those from other sources. So there's a lot to sort of delineate and kind of understand here, but this is just sort of like a general guideline to start. So the goal is the pattern. It's not to be perfect. Now, what about carbohydrates? This is especially important for diabetics. Carbohydrates are not all the same. And in fact, we talk a lot about these lower value carbohydrates, which we have here in that second column, the orange column, I should say. Things that I guess if you were to look at those items, you might think actually look quite good and you have a visceral reaction to enjoying them. These sugary sodas, maybe you see like a lollipop, some gummy bears there. These are the sugary drinks, sweets, refined flour, packaged snacks. Those are the ones where you can look at this curve actually over time. The glucose spikes really fast. It's those spikes in glucose that are problematic from a health perspective. Whereas higher fiber carbohydrates, beans, lentils, oats, berries, vegetables, whole grains, which is why we always look for that whole grain labeling on our food, can really blunt that glucose spike and subsequently the insulin spike as well. And you want to pair these with high quality proteins, healthy fats to reduce those glucose spikes when you're talking about a full meal. And that's where you can really make an impact. And for those of you who have a hard time with this, where it's indicated, you can actually get through your endocrinologist. Typically, this is rapidly proliferating, often, is a continuous glucose monitor or a CGM. Those are those monitors that many wear along their arm. And that can help you really understand your pattern to get an idea of, hey, what foods are actually spiking my blood sugar and which ones aren't. Exercise, which sounds kind of basic, but it's the most underused cardiometabolic medicine. In fact, for people who do not exercise, one of the best things you can do is just start something. It doesn't even have to be all that intensive because going from zero aerobic activity to having aerobic activity and or resistance training with it can significantly improve health and cardiovascular health, endocrine health, you name it. We improve insulin sensitivity, blood pressure, vascular health. Resistance training is particularly important because muscles have glucose receptors. This is why short walks after meals are so important if you can do it, because you have glucose hanging out in the bloodstream. And instead of it being stored away where it can cause damage or floating around in the bloodstream where it affects multiple organs, we are now literally sucking it up like a sponge into those muscles for use. So this is why oftentimes we say, hey, just get your exercise level up. But if you really wanted to timing it after a meal is very high yield. But the practical goal is that you want to build towards 150 minutes a week plus 2 days a week of some form of strength training. Strength training doesn't have to be, weightlifting these massive quantities. It really is just about engaging muscle groups. And that includes just all of sort of the major ones. So you could focus one day just on legs, focus just one day on arms or back or abdomen. Again, it doesn't have to be perfect. It's just whatever you find to be convenient and works easily in your schedule. I always feel like personally, it's easier to get exercise in when we don't make it a big deal. Like basically find 5 minutes here, find 10 minutes there, and find a way to just keep things moving, as I like to say. Now, in terms of weight, we talked about visceral adiposity and how that's problematic because it can worsen insulin resistance, inflammation, blood pressure, sleep apnea, et cetera. So even modest weight loss can improve glucose, triglycerides, all of the parameters that we're interested in. Larger weight loss can change diabetes trajectory. With GLPs, we can change it significantly because they are diabetes drugs. So we see the A1C come down pretty remarkably in these patients. So this long-term maintenance requires a plan always, not just willpower alone. This is one of the key points I wanted to bring up. Obesity is increasingly treated as a chronic cardiometabolic disease. It is not necessarily your fault if you have weight. This is a chronic disease. When we consider it as a chronic disease, it becomes so much clearer about what we need to do to try to improve it and get it to go away in the correct manner. A few other things that really can become problematic for patients who are diabetic and otherwise. Sleep apnea is common in these patients, and it's highly underdiagnosed. It's something we definitely want to address if it is, in fact, apparent, because if it is well treated, it can actually improve appetite signaling, insulin resistance, blood pressure. Chronic stress affects not just how you feel, but inflammation, autonomic tone, sleep. And if you have poor sleep, then you have a number of other issues. So these are all related. Smoking, which goes without saying, can accelerate vascular disease through indirect and direct mechanisms. Alcohol, which interestingly, there's been a little bit of like a trend to sort of consume less alcohol, and people seem much more happy to do it, which I never thought would happen. But it's actually quite fantastic because there's a lot of additional problems that can come with consuming even fair quantities of alcohol. So we're starting to learn that the best quantity of alcohol is probably minimal to none if you're able to swing it. And for those who do drink, to be exceedingly minimal in order to really be able to preserve their health benefits. But when all things are considered, you really still want to consider because diabetics often have high blood pressure and high cholesterol. So this is where medications for blood pressure, ACE inhibitors, angiotensin receptor blockers, some of you may be on these because they're so common. Statins, which many of you may be on because they reduce heart attack and stroke risk in diabetes. In fact, all diabetic patients by guidelines should be on a statin to reduce their heart attack and stroke risk because those benefits have now been seen over decades in a whole variety of clinical trials with significant magnitude of benefits. And many of you have many technologies. You don't want to consider these as homework. You want to consider them as helpful tools. Continuous glucose monitors, we discussed, they can reveal patterns in glucose response. Home blood pressure cuffs can help guide treatment. Smartwatches, many of you have. Activity trackers, we can encourage movement, detect rhythm issues, which might prompt you to come to a cardiologist. Daily weights sounds simplistic, but they're super important, especially for our heart failure patients, can detect subtle differences in fluid retention early. So basically, you want to use these technologies to support behavioral goals. They're not to make you more anxious. If you're the type who's likely to have health anxiety from having all of these different devices and technological tools, I would actually say don't hesitate to simplify. Make it as simple as just a scale and maybe a blood pressure monitor, maybe a glucose monitor if you really must, if you are in fact a diabetic and we're having problems managing your blood sugar. But you don't necessarily have to go all in unless there is really a clear interest in doing so and you're the type who is unlikely to be significantly impacted psychologically from that. So the cardiologist view is that from a purely diabetes standpoint, metformin, still a fantastic therapy. We've been using it for decades. It's great. It's well tolerated. It's appropriate. We have seen people use it throughout their life without significant issues. We talked about SGLT2 inhibitors like empagliflozin, dapagliflozin, with or without diabetes, GLP-1 and dual incretin therapies, finerenone. And then we talked about the foundational medications just a moment ago, statins, blood pressure medications, smoking cessation where needed are still the foundations, even for diabetics, because of the high comorbidity of cardiovascular disease. So we talked about some of this. A lot of this is just a little bit of rehash, but just so you know how these medications work, which we've discussed, in this case, SGLT2 inhibitors. Some common issues, just so you're aware, for patients who have frequent genital yeast infections, may have frequent urinary tract infections, have a dehydration risk. We try to avoid these medications. We can still sometimes pull it off in patients who really need them by having alternative dosing strategies or maybe trying multiple types of SGLT2 inhibitors, but those are sort of the main things. With GLP-1s and incretins, the main common issues are GI related, nausea, constipation, diarrhea, reflux. But we talked about all these different potential benefits too, and have been well delineated in these clinical trials. So they are great therapies for that reason. There's some examples here on this slide. And then we talked about finerenone and kidney and heart protection by targeting the mineralocorticoid receptor pathway involved in inflammation and fibrosis. So these are potentially medications that may be helpful for you personally as a patient. And then for aspirin, statins, blood pressure medications, I like this diagram here on the right. Basically, there are different forms of prevention. Primordial prevention, which is addressing some of these risk factors head on. Primary prevention, meaning like providing the right type of therapies to prevent a first event, like a heart attack. or heart failure, peripheral arterial disease, sudden cardiac death, and then secondary prevention, where if you've already had an event, now we really kind of want to dial in on these risk factors so that we really get you well treated. So prevention is layered. So lifestyle plus the right medications for the right level of risk. We try to give the right type of plan for the level of risk that you carry. So if you've seen me as a patient, you'll see that I often repeat that statement. And ultimately, this is shared decision making. Basically, we want to include you in that conversation, right? You should be engaged in that conversation. In fact, a good doctor is one who's really going to engage you in these conversations. The old model of that paternalistic doctor who just kind of tells you what they think and then you go off and do it does exist. I feel as though it's not really contemporary. Maybe some people do want to hear it that way, in which case we're always happy to shift. But the vast majority of the time, we are very happy to partner with our patients to really get down to like, hey, what are your goals and preferences? What side effects did you have in the past? What was your history? What is your family history? What's going on right now? Let's really delve into the particulars and delve into the numbers, and then that, prompts you to ask questions like, do I have a high plaque risk? Do I have heart failure symptoms? Is there any evidence my kidneys are dysfunctional? Is my weight affecting things, in a negative way? Am I at the right targets for where I'm supposed to be? So those are the kind of conversations you want to bring to your clinician, your doctor. Of course, just the red flags. When to seek care properly. I can't do a talk without talking about these. Of course, chest symptoms, shortness of breath, sweating, fainting. These are the things where you'd want to be much more alert, call emergency services. Stroke symptoms. There's this acronym called BFAST: balance, eyes, face drooping, arm weakness, speech difficulty. That is the quote unquote time to call 911. Heart failure symptoms for our heart failure population: worsening shortness of breath, more bloating, rapid weight gain, swelling, which we often notice on the lower legs. And then diabetes medication warning signs. Sometimes if you've been over medicated or if the diabetes medication is not quite working for you, dehydration, fatigue, vomiting, confusion, very low blood glucose, if you were to check, things of that nature would be red flags where you'd want to seek care urgently. So finally, and we're actually finishing at a decent time here, what I do want you to remember through all this is that diabetes is a cardiovascular risk condition. This is why I am here today as a cardiologist to talk to you about diabetes. It's not only a glucose condition. The kidney is often an early warning system for heart risk. This is what the most recent thinking is, and the most contemporary approach for us as cardiologists is that by looking at some of the kidney parameters, we actually determine your overall heart risk. So there is a big interaction there. Heart failure prevention matters just as much as heart attacks and strokes. You may hear all doctors say, we got to prevent heart attacks and strokes, heart attacks and strokes. It's almost like an automatic statement. But even the heart failure prevention piece is important because when all of these things are unmanaged, your heart failure risk does also increase. Lifestyle remains foundational. This is why we always address it in every visit. And everyone's interest in being lifestyle focused is actually well founded. However, it should also be practical, right? In the sense that lifestyle can often get you to a certain place. It's often with the modern medications and modern paradigms of treatment that we really kind of push it over to get you well treated. And when it's matched correctly for the right patient, we really then meaningfully move your care forward. And importantly, you want to know your numbers and ask these phenotype-based questions, as I like to say. Are my numbers good enough for where I am at personally, not just looking at blanket recommendations of like where those numbers are quote unquote supposed to be. So with all that said, just a quick plug on myself. I'm very active in media and on social. I've actually included all of my links here for those of you who are active on these platforms. I would love to hear from you, for you to engage. It's all there really just to be able to provide excellent public education. Is why I was interested in doing this today. Just trying to engage you all and really get you feeling good about the things that you can do to make your health better. So I'm always talking about contemporary topics, breaking down clinical trials. Sometimes it's fun, sometimes it's silly, sometimes it's personal, sometimes it's professional. Actually, say often it's professional. But you can actually scan the QR code there for all my links. I also recently started a newsletter. I would love for you to subscribe to the newsletter if you're more of a reader type as opposed to a social media type. That's on Substack. My website should be there out soon. But essentially, I have all these resources out there for you and growing, so that we can continue to do good work together. And just it's time now just for an open question and answer. If you have any specific questions, but of course, if it's personal medical decisions, of course, we obviously ask that you discuss with your specific treating clinician at the appropriate time. And thank you very much.
Thank you so much, Dr. Tadwalkar. This was an amazing presentation, and thank you for taking the time to really deep dive into this such an important topic. Yes, if you have any questions, please, any general questions that you'd like to ask, please feel free to unmute, raise your hand, type in the chat. I will also, in the meantime, pull up a poll question for everyone. Please take just a couple of seconds to answer, and I'll read it out loud. Do you plan to make any lifestyle or other health related changes as a result of what you learned in today's class? So just take a moment. It should pop up on your screen. And again, if you do have questions, please feel free to unmute, type in the chat. We'll give it a few minutes. This presentation is being recorded, so you will get the recording within 24 hours. You can watch it whenever and share as well. Got a few responses. Any questions? There's a question in the chat. Let me pull it up. 1 second. At what A1C do you become concerned for prediabetes?
Yes, great question. So when we look at, so it's interesting, before we even did A1C, so let's just kind of dial back even a few decades ago, I sort of came into medical training just as A1C was kind of taking off as a metric. Before that, there were these very strict criteria that you sort of had to do these glucose challenges to sort of, diagnose diabetes and impaired glucose tolerance, and it was quite cumbersome. A1C kind of changed the game as it relates to diabetes and prediabetes and just glucose tolerance because it became the metric of choice because it was so reproducible and with very few exceptions, it's an accurate metric for just about everybody. With all that said, when we look at A1C, the range that we get concerned for prediabetes is when you jump into this 5.7 to 6.4 range. We call that impaired glucose tolerance. That is prediabetes. Importantly, what's important to remember is that it is a spectrum. So the higher end, you're much more closer to being diabetic, whereas in the lower end, you're much more closer to just not even having an impairment in glucose tolerance. So there are different levels within impairment of glucose tolerance or within prediabetes. And to be fair, a lot of these cutoffs are a little artificial, right? Just because you jump from, say, 6.4 to 6.5 doesn't meaningfully mean like that you just made some big jump. You were already kind of on that prediabetes, diabetes like borderline, and you would essentially be, essentially treated as either in that specific situation. But those would be the way to kind of frame A1C. But if you kind of wanted a very strict metric, 5.6 would be your cutoff. But I wouldn't get overly concerned off the top if you were like 5.7, 5.8, because again, you're so close to being within that normal range. It wouldn't necessarily be a means to perform medical intervention. It'd be a little more, for most people, more lifestyle oriented.
Thank you. We have two thank you comments. Thank you. This was a very helpful and another very informative and clear talk. Really enjoyed listening to it. Good pointers on what one can do to prevent heart disease. So thank you for the information. The following question reads, what fruits to stay away from?
Right. Yeah, that's a good one. So, you can actually look a lot of this up and to get like a full list, but there's a couple of things to remember with fruit. One is how much sugar sort of content there is inherent within the fruit itself. And some fruits are more sugar heavy than others. But beyond even the overall sugar content, you actually want to look at the glycemic index. So, how fast does that specific fruit raise your blood sugar? So, ideally, you want something with a low glycemic index and low sugar quantity. This is actually why on a lot of people really do prefer eating berries and put berries in everything because they induce satiety actually with just a few of them, like you don't need a large quantity, and they're unlikely to spike your blood sugar rapidly. On the other hand, there are some fruits that technically have high sugar content that are worth knowing. It doesn't mean you should stay away from them completely because they are still fruits that have content, vitamins, minerals, and other content that is actually quite healthy. But those include probably the most sugary fruit is probably mangoes, even though they're very tasty. Another is watermelon, very high sugar content. Many people feel that because of the high water content that comes with it, that it sort of is less worrisome in terms of glucose spikes. Grapes have high sugar content. So those are just some to be mindful of. Doesn't mean you shouldn't consume them. You just should be a little bit more careful. But definitely look for those lists in terms of like what's more sugary versus not. What is, more likely to rapidly increase your blood sugar versus not, because both of those parameters are important.
Thank you. We have one last question before we wrap up. I'm aware bread has sugar or turns into sugar. Is there any specific bread I could choose? I like bread.
Yeah, sure. So, yes, a lot of people like bread because a lot of people like carbohydrates because they're just tasty, right? And it's true that, as opposed to maybe in the past, like, we would say, um, like the dietary advice would be more like, all right, let's just cut out carbs, let's cut out fat, and, that's how I'm going to get healthy. And it's not quite that simple. It's more about having the right types of different macronutrients, right? So, you want to have carbohydrates, you just want to have the right type. You want to have proteins, you just want the right type. You want fats, you just want the right type of fat. So within the carbohydrates, yes, you should consume carbohydrates, you just want to find the right type. So in terms of bread, this is actually a perfect example where the simplest, I would say, initial delineation or disparity is really just, okay, white bread versus non-white bread, because white bread is that refined starch and, is the closest thing to sort of like sugar. The same thing goes for pasta, like sort of the white versus wheat pasta, where, whatever is going to break down quickly into simple carbohydrates, which are the whiter versions of it, are actually worse for you from a glucose and diabetes standpoint. On the other hand, those that are wheat, or if you look specifically for labeling that says whole wheat and non-processed, um, these are the kinds of breads that you want to look for that are a little bit healthier and in moderation could actually be quite, part of a healthy diet.
Thank you. Thank you all for your great questions and thank you all for the lovely comments. We do agree, Dr. Tadwalkar, this was an amazing presentation, very thorough. So I hope everyone found this informative and just useful. And you can watch it again within 24 hours. Everything will be emailed to you. We hope to have you again soon. Dr. Tadwalkar, I hope you enjoyed your time with us. Thank you
Absolutely.
all. Have a great day and we hope to see you at the next Health and Wellness Talk. Thank
Thank you, everybody.
you.
Much appreciated.
Bye.